So we talk about antenatal hydronephrosis. I'm sure that there is everyone in this crowd must have ever faced a report with swelling in the kidneys, hydronephrosis, and you must have had their doubts of how to manage or how to go about it. So my job in the next 20-25 minutes is just to simplify things for you. By no means So just before we start, some terms. Isolated hydronephrosis is hydronephrosis in the kidneys without any ureteric or bladder abnormalities. Bilateral hydronephrosis, as the word goes, is involving both kidneys, or if there is a solitary kidney, then hydronephrosis in the solitary kidney. And then APD, we'll come to it a little later. What is the APD? So antenatal hydronephrosis is diagnosed in almost 7% of all pregnancies. It varies by definition and gestational age. Almost 30% of it are bilateral. Again, natural history will depend on what the etiology of the hydronephrosis is. Almost to the tune of 15% they require postnatal intervention, and outcome depends on what the underlying etiology is. While majority of identified cases they resolve spontaneously within the first 1 or 2 year of life, unfortunately there is no single finding or study that can accurately differentiate an infant with a clinical significant disease and a benign disease. So when you see a report, there is no marker that you can confidently say, okay, this child is not going to need anything postnatally, or this child is going to need something postnatally. So let's just proceed to the case. We have an antenatal ultrasound at 19 weeks of gestation which shows right kidney AP diameter of 8 millimeters. So is this significant? Anybody from the audience? Is this significant? More than 10 in the first trimester? Sorry, second trimester? Any other views? Amol, any inputs on this?
So we are in the second trimester, in 18-19 weeks scan. This is the easy way to remember month-wise rather than weeks-wise. 4 months of pregnancy, 4 millimeters, 7 months, 7 millimeters, and right term 10 millimeters.
Okay.
It's easy to remember rather than getting confused with weeks. 4 months, 4 millimeters, 7 months, 7 millimeters, 10 months, 3. At term, 10 millimeters. If it's more than that, then it's significant.
So yes, as rightly pointed out, and in an easier way, any APD more than 4 in the second trimester and 7 will be moderate, and then more than 10 will be 10. So this was based on this meta-analysis which was done, and as the AP diameter increases, the risk of pathology, it being abnormal, goes on increasing. As you know that urine output almost increases from 7.5 ml at 25 weeks every hour to about 27 ml at term, and that is why they increased sizes to accommodate for the increased urine output. So why knowing this is important? It will help you in prenatal counseling, one, and second is to manage plan the postnatal management. So the bottom line, significant dilatation 4 mm in the first trimester, 7 mm in the second trimester, and more than 10 mm in the third trimester. Now, what are the common causes of dilated pelvic coalescent system that you can see on antenatal ultrasounds? See, everybody has seen this picture in their outpatient practice, so let's have some input from your end. What are the common conditions that can cause this dilated pelvic coalescent system? PUJ obstruction, posterior valves, PUR. So these are the 3 most common things, but there's something, most of them are transient hydronephrosis, as you see, almost to the tune of 40 to 80%. Then PUJ obstruction and PURB becomes the most commonly identified abnormalities on antenatal scans. And then there are others like PUJ obstruction, any duplex kidneys, posterior valves, multicystic dysplastic kidney, and these are the possible reasons where you can have urinary tract dilatation on antenatal ultrasounds. Remember, transient hydronephrosis is the most common thing, but you also have to keep in mind that there can be something abnormal which needs further evaluation. So, what additional information do you need from the antenatal USG? Are you happy with just anterior-posterior diameter of the kidney is 8 millimeters, or do you need something more to plan and counsel the family? Cortical thickness.
AP diameter and cortical thickness of the kidney.
Right. Anything more? SFU grading. Somebody I heard in the crowd saying SFU grading. Anything else that you want to know more?
Family history of the patient.
Family
Past
history.
history.
Okay.
Patient.
No, on ultrasound, what do you want to see? You have an ultrasound report of AP diameter 8 millimeters in one kidney. What do you want to know? Oligohydramnios, that is the amniotic fluid volume. I heard some murmur around the center. Please be clear. Okay, so what we want to know is how is the opposite kidney? Is it good or that has some dilatation? Does it have any, what is the echogenicity of the kidneys? Are the kidneys appearing very bright on ultrasound? Are there any cysts? Cysts in the kidneys can be a sign of dysplasia. So that is what you want to know. Is the bladder emptying completely? Then what is the amniotic fluid volume as rightly pointed out? Are there any other anomalies in any other structures in the body? And are there any soft signs that may point towards a syndromic thing rather than just isolated hydronephrosis? So what are these soft signs? So any thickened nuchal fold, echogenic bowel, ventriculomegaly, echogenic focus in the heart or thoracic plexus cyst. Any of these, it increases the chances of it being a fetal aneuploidy, and the hydronephrosis is the part of that aneuploidy. Then the single umbilical artery, as we all know, is associated with some abnormalities in the kidneys. And then pyrectasis is associated with risk of non-chromosomal abnormalities. Then we all know how we define oligohydramnios, so I can skip that part. And suspected lower urinary tract obstruction, if you have bilateral hydroureteronephrosis, which is associated with dilated thick walled bladder that fails to empty, or a dilated posterior urethra and or oligohydramnios. This all points towards a lower urinary tract obstruction. Now, how do we define fetal hydronephrosis? As we discussed in the first slide about the anterior posterior diameter, the one mark on the right is so this is what the anterior posterior diameter of the renal pelvis signifies, and the 4, 7, 10, whatever we are talking about was the diameter of this particular part. Okay. Now the pelvic dilatation, as I said, is also determined by the gestation, the hydration, and the bladder distension. It is objective way to classify hydronephrosis, fetal hydronephrosis. It is reproducible. Like if there are multiple observers doing the same ultrasound, we can obviously measure the sizes. It has low intra-observer and inter-observer validation, but this classification does not take into consideration if there are chalices which are dilated or if there is any parenchymal changes. So there was a need felt to define this dilatation more precisely, just to guide postnatal management and the course. So this the new system that we use nowadays is the UTD, or the urinary tract dilatation classification. It takes into account both the anterior posterior diameter of the pelvis, whether there is any chaliceal dilatation or no, whether there is ureteral dilatation or no, and are there any other parenchymal abnormalities or bladder abnormalities. So now let's reclassify our case according to this classification now. So antenatal ultrasound at 90 weeks of gestation showed AP diameter of 8 millimeters. So that comes to UTD A1, that is antenatal urinary tract dilatation in this category. Okay. So now at 19 weeks, this is the status. So when should you do the next ultrasound? Or when, obviously the obstetrician will be the one who guides the ultrasound, but when would you recommend doing an ultrasound in the antenatal period? So this is in the second trimester, at least one in the third trimester. So now, if you have a unilateral hydronephrosis, you repeat one in the third trimester and then postnatally, we'll talk about it later. If you have bilateral severe hydronephrosis, you will need serial antenatal ultrasound every 2 to 6 weeks just to monitor the oligohydramnios and the worsening. If you have any soft signs or systemic malformations noted, this child needs access to specialized center with genetic counseling and maybe facilities for amniocentesis or any prenatal diagnostics. So we have this child 19 weeks, and how will you evaluate this child now? Suppose this child is born at term, is good weight, and how will you evaluate the child after birth? Day 3 ultrasound. Before ultrasound, would you want to do something else? Urine output, very good. Excellent. Anything else? The clinical exam? Yeah. Look. Examine the baby, examine the genitalia, examine the spine if everything is okay. Look for the urine output. Do a urine routine if baby has some UTI, and also a postnatal ultrasound after 72 hours. You have to take into consideration the neonatal dehydration and the diuresis, which sets in after 48 hours. And also, like, there is high chances if the baby is thriving well, looking well, that there can be loss to follow up. So, if you have to work up a child with antenatal hydronephrosis, you can also do an ultrasound earlier if you suspect a lower urinary tract obstruction, like if you have a bilateral hydronephrosis with oligohydramnios, thick bladder wall, which is not emptying, or if you have a hydronephrosis in a solitary kidney, that sometimes kind of becomes an emergent situation to work with. So then within 24 to 48 hours, you can still ask for an ultrasound. If you have unilateral hydronephrosis, ask within 2 to 7 days. As a rule of thumb, it is better to get one ultrasound before the baby is discharged from the hospital. That is generally day 3 to 4. So it's ideally, if we get an ultrasound before discharge, that serves a purpose. And if the first ultrasound is normal, you again confirm it a month later or a month and a half later, and you follow these babies till you find a diagnosis of what's happening, what is causing the hydronephrosis, or the hydronephrosis resolves. So postnatally we did the ultrasound and APD was 11 millimeter, and now it becomes UTD P1. So what next? What next questions come to your mind? Ma'am, what would you think next?
We need to rule out other anomalies, whether there is PUJ obstruction. We need to monitor the urine output also. If there is oligohydramnios on the, whether there are other conditions different from that.
Professor, will you give this child urinary prophylaxis?
Recently, we won't rush for urinary prophylaxis. Initially, we used to till we evaluate further. So definitely, at present, no role of prophylaxis.
And this is on day 3. So when will we repeat the next ultrasound? 4 to 6 weeks. Does this child need MCU or nuclear imaging right away? No. Okay. So let's now check the algorithm of how to proceed with a postnatal ultrasound. Initial scan is the first week, repeat at 4 to 6 weeks. If there is no dilatation, there is no intervention. If there is dilatation, APD 10 to 15 millimeters without additional abnormalities. Repeat ultrasound every 3 to 12 months and follow up until it is resolved. If there is UTD-P2, like APD is more than 15, or there is some callicial dilatation or has additional renal abnormalities, or if there is UTD-P3, APD more than 10 millimeter with bladder abnormalities or antenatal oligohydramnios, these children will need to see what the sequential ultrasound shows and decide if you need to do an MCU in this child. If the MCU is normal and the dilatation is worsening, the plan would be to go for a dynamic renography to see if there is PUJO. If the ultrasound on the sequential ultrasound and micturating cystogram show a VUR, then this child deserves antibiotic prophylaxis depending on the grade of the VUR. And if you have a lower urine tract obstruction, then we need to get in a pediatric surgery consultation. Now coming to the diuretic scans, if it is normal, you just continue to monitor the ultrasound sequence, the hydronephrosis sequentially, and if you show, if there is an obstructive pattern to the flow, or if there is a low differential function, if the split function is like say 30%, 35% or less, or 40% or less, then obviously that needs a pediatric surgery consultation. I think you can skip this. 22-week gestation, USG shows bilateral hydronephrosis, left kidney AP diameter is 8 mm, right kidney is 7 mm, classifies as usually A2, A3. Now what are the common causes of bilateral PCS dilatation? Posterior valvular and VUR. Okay, these could be the two things. Now, what will you look for in the ultrasound? We already discussed this. Okay, we look for whether the bladder is emptying completely, if there is oligohydramnios, what is the appearance of the kidneys, are they hyperechoic or are they diseased, are there any other malformations. Now, when will you do the next ultrasound? So this was at 22 weeks. When will you do the next ultrasound? 32 weeks. So we did one at 34 weeks, and left kidney shows AP diameter of 9 and right kidney shows AP diameter of 10 mm. There is no oligohydramnios now. Baby boy was born 2.9 kilos, healthy at birth. What will you look for postnatally? Or what will you tell the parents to look postnatally?
We need to monitor the urine output first.
Very good.
Then we need to examine the genitals, as
Right.
Amol suggested.
Right.
And after that, we need to palpate the abdomen also, whether there is any lump for suspicion of the polycystic kidney also. Because there are so many scans, they are missing antenatal diagnosis. So we need to confirm that after postnatal period. And also we have to monitor for the renal function.
Right. Anything else, Amol, you would want to add?
I would want to ask the parent to once undress the child completely without diaper or langot and watch for the stream of urine that is coming out, whether it is continuous, whether it is forceful, or whether it is dribbling on the thigh. Easy way to ask is मांडीवर पडते का? Or is it crossing? Then parents have nice descriptions. तोंडापर्यंत उडते, माझ्यावर उडते. That is happening to listen. Okay, but त्याच्याच मांडीवर पडते का? थांबून करतो. Something to worry.
Right. So as we discussed, if you have bilateral hydronephrosis, the most common entity that we look forward to diagnosing postnatally is a posterior valve, which will have an obstruction in the urethra and cause poor urine stream, or the baby will strain or cry while passing urine. So these are something that you need to monitor. Also, do not forget to examine the spine of the baby. You can have surprises anytime. So look for urine output, the voiding pattern, palpable bladder, kidneys, spine examination, urine routine, everything. Now, when will you do the postnatal ultrasound? You can do it early because we now suspected a lower urinary tract obstruction. We did a postnatal ultrasound on day 2. It had bilateral hydronephrosis and a thickened bladder wall. How will you manage this child now? We have a urine routine which is normal. You have catheterized the baby because the baby was not passing urine. MCU. Okay. So you will do an MCU under antibiotic cover and strict asepsis. And this is a rough guide to like when to do an ultrasound MCU urgently within like 24 to 40 hours if you have bilateral hydronephrosis in a solitary kidney or an abnormal bladder and suspected lower urinary tract obstruction. You can wait for doing an MCU if you have just a dilated ureter, dilated chalices, and you can then plan it doing it like after seeing the subsequent ultrasound at 1 to 1.5 month age. So we did an MCU and this is what it showed. Anybody? What is this arrow signifying? A grossly dilated posterior gland. And any PGs who can try and grade the reflux here? What grade? What grade on this side and what grade on this side? So yeah, probably grade 4 on the right and
Left side grade 2.
Within 2 to 3 hours. Yeah. So here we call in our surgeon friends, and you have a diagnosis of posterior valve with bilateral VUR. Fulguration was done. We did a creatinine before surgery, which was 1 milligram per DL, which reduced to 0.5 milligram after fulguration, and the baby now has a good stream of urine.
One thing, this would, if we're suspecting posterior valve, before we are first time catheterize the baby, don't be very enthusiastic about catheterizing the baby forcefully. Whatever is the smallest possible infant feeding tube that you can use, please use that. At any point, if you find that it is difficult for you to negotiate the catheter perulatorily, do not force. Do not force to put it. Call in the pediatric surgeon.
So this is the status after fulguration. Is this time to rejoice? Is anything more needed, or your job is done? Follow up. So what kind of follow up do you want? Like, what are the things that you're looking at follow up? Kidney functions, blood pressure, height, weight, the growth of the child, urinary stream, which is now normal. We have fulgurated the valves, the obstruction is gone.
Urine output,
Whether
it's solid or
right?
the drinking of the urine.
Yes, so stream is good. That we have taken care of. Anything else? So UTIs, monitor for UTIs. You give them how to be vigilant. Give them guidelines when to do a urine routine. And would you repeat ultrasound again or no?
Yes.
Yeah, serial ultrasound. What do you want to look at serial ultrasound? So BUR will not be visible on the ultrasound. Hydronephrosis is the APD coming down. Then
Brightness of the urine.
brightness, bladder thickness, echogenicity. Something more important. As you're doing sequential ultrasound, do you want to
VUR also.
The VUR will not be picked up. That we just discussed. The VUR will not be picked up on an ultrasound. Do you want to see something growing when the baby is growing? The kidneys. Okay, are the kidneys growing as the baby is growing? So these are the few markers of renal injury where you see the serum creatinine at 1 year, one year after fulguration. That is we call the Nadir creatinine, and that can predict what the future renal functions are going to be. Look for any acidosis. Look for scars in the kidney. That will be obviously on DMSA, and if the scar is very prominent, you can also see sometimes from the ultrasound if an experienced sonologist is doing it. These kids have to be monitored at least till they attain 5 years of age and even further, because at 5 years we expect the bladder to mature and they should have the full bladder control by now. But there can be something called as valve bladder, which is either a high pressure bladder or a very atonic bladder. We don't know which way the bladder is going to behave after we have fulgurated the valve. So there is something you also look at the voiding patterns. How is the child voiding? Look for post-void residue if the child is emptying the bladder completely or no. Look for kidney sizes, and we did not touch this proteinuria. It is a very early onset marker of saying that there is something wrong in the kidneys and that needs to be looked on. It's a marker of glomerular damage, the low-grade proteinuria. Okay, now moving a little away from hydronephrosis, something very commonly seen on antenatal ultrasounds. Antenatal examination revealed left kidney enlarged with multiple cysts, right kidney normal. Postnatal, the left kidney is 5.4 centimeter in length, multiple cysts ranging from 0.5 to 2 centimeters, right kidney 4 centimeter. The report says polycystic kidney disease. How many agree? How many disagree? How many agree that this is polycystic kidney disease? Nobody agrees. How many agree that this is not polycystic kidney disease? Okay, just one hand. Rest all refer to other sonologists for a different ultrasound. Yes, madam, what is your take on this? Is it polycystic or not polycystic?
It is not polycystic.
Very good.
Because we need to monitor the serial monitoring of the USG also, and the centimeter right kidney measurement is 4 centimeter in there. That is already normal. The left kidney 5.4 is just the higher normal level. So I think we should repeat the scan and we should get the another.
Okay. So there is somebody who disagrees with the diagnosis of polycystic kidney disease. Anybody in favor of multicystic dysplastic kidney? Pankaj sir, could you please highlight some points about how to differentiate what is polycystic kidney disease and what is multicystic
Most
dysplastic?
importantly, polycystic kidney disease is a bilateral disease. It's not going to affect single kidney. This is very common mistake. Single kidney showing multiple cysts and then labeled as a polycystic kidney disease. So it has to be multicystic dysplastic kidney. And if you see both kidneys getting affected by multiple cysts, it cannot be multicystic dysplastic because bilateral MCDK is non-viable fetus. So if it is unilateral multiple cysts with enlarged kidney, differential will be multicystic dysplastic kidney.
So yes, as rightly said, this should be bilateral and this is generally unilateral, and if it is bilateral it is incompatible with life. The kidneys are large sized. When you have polycystic kidney disease, you can obviously see them when the baby is born, like the abdomen is very full, and the affected kidney on the multicystic dysplastic side can be either large, normal or small size. The cysts are small in polycystic kidney disease and it is associated with some other abnormalities also like congenital hepatic fibrosis. The cysts are very varying sizes and there is no intervening parenchyma which is there in the cyst when you have a multicystic dysplastic kidney. Polycystic kidney disease invariably progresses to end-stage kidney disease. And multicystic dysplastic, if it's just a contralateral kidney is normal, then there is no renal failure. Okay, a single kidney, solitary functioning kidney is very well compatible with life. Obviously, you have to give them some precautionary advice about avoiding NSAIDs, keeping the child well hydrated and having blood pressure assessments regularly. Again, multicystic dysplastic kidney, when if you still have it in your body, there is a risk of UTI, hypertension and risk of malignancy. They generally wither away and they develop autonephrectomy when as the child grows. So nothing needs to be done, just preventive care and some prospective advice to be given to the parents. So in a nutshell, hydronephrosis is defined and graded antenatally and postnatally using UTD. Serial ultrasounds is what we need. At least one ultrasound in the third trimester is needed. We can decide which kids need to do FCO and diuretic renography based on serial ultrasound postnatally. And prophylaxis, as Amol pointed out in his slides earlier, also is limited to child with VUR. Now, if you have been not listening to what I have been saying, I don't mind. Just take one point home, that newborns with antenatal hydronephrosis, including with prenatal resolution, should have a postnatal ultrasound. This is the crux of the matter. Even if you have noted a ultrasound which is at the 20th week which showed hydronephrosis, and then in the third trimester scan you did not notice any hydronephrosis, even then this child deserves at least one ultrasound postnatally. And that would be the message that I would like to give to all of you. And yes, so as William also said, medicine is a science of uncertainty. You never know what's happening inside, and it's an art of probability. So based on these all ultrasound, physical exam, your ongoing monitoring, you can just probably say, okay, this child is having this, and then try your investigation accordingly, so that you don't unnecessarily investigate and you don't unnecessarily miss any major thing. Thank you.